Welcome to Discussions with Global Leaders, brought to you by MedNews Week. I am Sean Jackwitz, and we are excited to be speaking with Dr. Jay Fishman, the director of the Transplantation, Infectious Disease, and Compromised Host Program, and the associate director of Mass General Transplant Center at Massachusetts General Hospital. Here in this video, he discusses the latest developments in xenotransplantation and gracefully answers all of our questions. It was really fantastic to have our team talk to him, and it was an amazing discussion. So I hope you enjoy. And now let's get right into it.
I had a question of my own to ask. You spoke a little bit briefly about some of the regulatory and ethical hurdles that you face, and then a lot more about the technical and scientific hurdles. What do you foresee as the greatest challenge in improving xenotransplantations?
I'll tell you, I think the good and the difficult are probably the same. I think the biggest challenge is public acceptance. You know, the notion that you're going to put an animal organ into a human is a little bit out there. It's a little bit unusual. And so conceptually accepting that, I think, is a little bit difficult. It's not wrong, because it actually encapsulates the fact that there are immunologic challenges and metabolic challenges and these infectious challenges that I've just talked about. But there are people who might say, you know, I'm not sure this is such a great idea. I should mention that all religious authorities of all the major religions feel this is acceptable to save a life. So that it's not a question of a pig versus some other animal or putting it into a human. To save a life, all of the major religions accept xenotransplantation conceptually. So the question is, can we make it safe? Well, that shouldn't be any different than any other major therapy. You introduce a new drug, a new vaccine, a new technique, and there's a lot of new techniques. And the advantage of xenotransplantation isn't just addressing the organ shortage, but it's also the knowledge that we've gained about immunology, about organ perfusion, and thinking about infection that we wouldn't have had otherwise. So that there are some things we've gotten, even if we never get into the clinic, but I'm hoping that we do.
Thank you. Yeah, that was a great answer. Thank you very much.
So, Dr. Fishman, my question to you is, you mentioned the use of CRISPR-Cas9 strategy to inactivate the PERV element in the porcine genome and to create PERV-free pigs. So have there been any reports of any off-target mutations? And if so, how can we prevent these mutations from occurring? I would love to hear your thoughts on this.
So for those of you who aren't familiar with CRISPR-Cas9, it relies on a guide RNA sequence. That means it has to match the target that you're trying to either get rid of or where you're trying to introduce a new gene. And so the strategies, there's a whole variety of strategies, but the idea would be that you could introduce errors in this case, the polymerase gene of the porcine endogenous retrovirus, which was very successful and inactivated all of the PERV copies. So you ask a good question, which is, these guides don't match necessarily perfectly. So how many off-target effects did we see? And the answer was actually very few. It was a range. And so that the cells that were used to create this pig line were the ones that didn't have demonstrable off-target effects, but some off-target effects did occur. Now, I should, by way of disclosure, say that it wasn't just the PERV that was altered now in the most recent round of pig breeding, because what they're doing is introducing some regulatory genes to prevent complement deposition, prevent clotting on the surface of cells. They're knocking out a sugar that prevents rejection. There's about 10 or 12 different modifications that are either introduced as a single cassette or as a series of CRISPR modifications. And so with each of those, as you suggest, there's a small but real issue of whether or not you're hitting the right target, or maybe you're doing something in the wrong region. But you can actually measure by sequencing the genome when you've put something in the wrong place. And we've done that. And it turns out that you can select cells where that hasn't happened. All that said, the technology in the last, I'd say, 5 to 7 years has gotten a lot better. The guide sequences have gotten better, and therefore the accuracy of this manipulation has gotten better. But it's not perfect. And therefore, but we have a test for this, certainly in pigs, because generally the pigs with anomalies are not born normal. And so that the animals that are born to be normal actually look normal and act like normal pigs. And they feed normally and they grow normally. And so you can do a variety of manipulations, but the ultimate answer is the pig normal morphologically? Does it have normal metabolic functions? And when you sequence the cells, you have genes that are in the wrong place. And if you pass all of those, then I think that the answer is that you've actually been quite successful. It's not a perfect science, as you probably know.
Thank you so much, Dr. Fishman, for such an amazing answer. So now I'll be passing on the mic to Shrivika for the next question.
So, hello, doctor. First, I would like to thank you for such an interesting presentation. It was really an eye-opener. So, my name is Shrivika Kannan, and my question to you is, what is your opinion on the role and the importance of a diet for like a transplanted patient?
So I would take a little step back, and I would say that one of the most important things we do as transplant physicians and surgeons is think about the goal. The goal is that we want people to have healthy and good lives. It's not to just survive. It's to go back into society and be productive, to have children and grandchildren, and to be able to interact with society in a healthy way. In many ways, you have to think about how people get to organ failure and transplantation. Now, many people, for example, have infections and they end up getting heart disease or lung disease or liver disease, and others have other habits that may lead to organ failure. All of it's the same. We just take care of the patient. And so what we try to do is ask people to live healthy lives. So it's not just diet. The diet is important. We want people not to be obese. We want people to have active lives, so we need them to exercise. We especially need them to get vaccinated against common organisms. They shouldn't avoid pneumococcal vaccines. They shouldn't avoid flu vaccines or COVID vaccines or others, because these are basic protections for individuals who don't have a normal immune system. So a normal, balanced, healthy diet, but it's really about lifestyle. But it's not about stopping living. It's not about not seeing your grandchildren or not traveling. And I can tell you about any number of patients I have that send me postcards from places that I would say, oh, don't go there, it's not safe. It's true. And so what you really want to do is each time is think about what you're doing, but in reality, it's about living a high quality life.
Hello, doctor. Thank you so much for your amazing presentation. I really learned a lot. My name is Gayatri, and my question is, I just wanted your thoughts on the use of novel technologies such as single-cell RNA sequencing or spatial single-cell transcriptomics to basically kind of address the organ-specific incompatibilities during xenotransplantation. So I'd love to hear your opinion on this.
So I can't answer it directly. I'm going to cheat a little bit because what we've done is single cell sequencing and to look at the effects, for example, of various viral infections on various immune cells in the body. And so, for example, if you take a virus, like a common virus, like cytomegalovirus, which I've told you is in 80% or so of our population, it changes the way a cell functions because it infects it and it changes what the cell does. So can we use the same kinds of tools to ask the question, is an organ functioning appropriately in a new environment? Or can it address the metabolic concerns? And the answer is only partially, and those studies are in their earliest stages. So I don't have an answer. I think that what we can say is that we are studying the metabolic function of whole organs in primates. And so you can tell whether or not they are appropriately regulating various metabolites, cholesterol, uric acid, can they digest vitamins and use them appropriately? But we don't have the level of detail that you're talking about. It's important though. And the reason it's really important is something that wouldn't have been important a decade ago, which is we now can insert genes or take out genes that might be detrimental to the human host. And so the ability to modulate perhaps the metabolic functions of the donor organ is huge. And so exactly the technology you're talking about can be used to examine at the cellular level whether or not these cells are doing what they should do, but we don't yet know. And so these are ongoing studies. My lab and my collaborators are studying the effects of viruses at the cellular level. Other people, and I'm sure the Food and Drug Administration will be very interested, for example, in how well various pig organs can function metabolically in a human host.
Thank you so much, Dr. Fishman, again for such a wonderful answer. So for the next question, I will be passing on the mic to Ahmed.
Thank you, Ms. Khan. Hi, Doctor. I just want to say that it was such a wonderful talk and session. Like, I think xenotransplantation, at least personally, was such a novel topic to me, and to be able to learn so much from one session was amazing. So thank you for that. And as for my question, given all the post-transplantational infections that develop, how close do you think we are in developing effective antiviral medications against?
So I had a little trouble hearing, but I think that what you said is how close are we, or how effective are the antiviral medications we have in preventing and treating infections that might come from pigs? Is that correct?
Yes, exactly.
Yeah, okay. Many years ago now, we started studying some of the antiviral medications, for example, for porcine endogenous retrovirus and the porcine cytomegalovirus. And what we found was that the human antiviral medications, for example, for cytomegalovirus, didn't work as well for pig cytomegalovirus. The virus sequences are a little bit different. We actually sequenced them. And so it wasn't a huge surprise, but it meant that the strategies that we routinely use for human-to-human transplantation for CMV might not be as effective. So it was better to spend our efforts trying to exclude PCMV from the donor animal than to try to treat it afterwards, as we do in human-to-human transplantation. So this was a different strategy. Remember, just to put it on a sidelight, when we accept an organ, a human organ for transplantation, we have a limited number of hours before it has to be implanted into the recipient because it won't survive. That also means we have a limited amount of time to do microbiologic testing. And so many of the results we get back after the organ, has already been put in. So that we often have to catch up a little bit in human transplantation. It's fine, it's what we do routinely, but it does mean that we have some opportunities in xenotransplantation that we might not have in allotransplantation. So let me go back to your question, which is for porcine endogenous retrovirus, I've already mentioned that we can knock it out of the donor animal, but let's say we don't. Well, it turns out that there are a large number of antiretroviral drugs that were developed for treatment of HIV that also are effective in tissue culture against PERV. And therefore, should infection occur or should infectious exposure occur, we have alternatives for therapy for PERV. So the PCMV and the porcine endogenous retrovirus were the two biggest concerns, and we have therapies for those. We don't have information about the susceptibility of many pig viruses to other antivirals. So I have to plead ignorance. It's not that it's not important, we just don't have data yet. We have some diagnostic tools, but we don't know much about therapy. So the bias here is to exclude what we can from the source animal because we're not sure that we're going to have effective antiviral therapies for the recipient.
Thank you, Dr. Fishman, again for a wonderful answer. So for the next question, I will be passing on the mic to Madhuri.
Despite a lot of the challenges in xenotransplantation,
Right.
what are you most excited about for the future of it?
I think two things. One is, of course, having a supply of organs to meet the need of transplant recipients. When you take care of sick people, the lack of organs for transplantation is a terrible thing to watch. And so people just can't always find an organ in time to save their lives. I think, though, that for me in my career, the approach, if you will, not supposed to use this word, but the fun of it is that, yes, we're going to be helping people, but there certainly are ethical challenges, there are biologic challenges, there are technical challenges, and the community has come together really very nicely to work together to make xenotransplantation work. But as I mentioned before, if the public doesn't accept it, it won't work. If the regulatory authorities, the Food and Drug Administration, our institutional review boards don't accept it, it won't work. If our scientists don't work together and our surgeons and everyone else, it won't work. And so in my experience, there's a greater degree of scientific and ethical collaboration than I've seen in many areas. And transplant by itself has always been ethically challenging. And so the fun of this is to see really good people working together to make xenotransplantation a reality. And I think that's part of what we should be trying to do. It's a model for what we've seen in science, and I think that's a good model.
I want to know that, according to you, what is the current challenge or barrier for researchers and doctors to take xenotransplantation into use on a larger scale?
What's the barrier for taking it into clinical use? We need a lot more information. I think that, there are certain regulations that come largely from the Food and Drug Administration for introducing new therapies. It's true of any new therapy, and it's a good thing. What they include are certain experience in regular transplantation, preclinical studies in primates and non-human primates that are successful, so they want survival of pig xenografts in primates. They want an immunosuppressive regimen. They want drugs that will be tolerable for humans, which makes perfectly good sense. They want the institutional review boards to say this is ethically acceptable. And so, as I said, I see this as a package, but the biggest barrier is getting all the pieces together so that we can say we're ready. And even in the last weeks, I've dealt with people in infection control and people developing pigs and people studying immunosuppressive regimens. We all have to work together to create the protocols for clinical trials that will be acceptable. And that's a huge challenge of getting people, even people of good spirit, to work together, because it takes a lot of time and a lot of creativity.
What a wonderful answer. Thank you again, Dr. Fishman. And for the very next question, I will be passing on the mic to Pratyusha.
Thank you, Muskan, and thank you, Dr. Fishman, for that amazing, amazing lecture. I certainly learned so much about xenotransplantation. So my question to you is, you are also an educator. So can you discuss the synchrony between high quality patient care and also educating the next generation of physicians and physician scientists?
Thank you for that question. It's an important one. Each of us has a story to tell. And as you heard at the introduction, I was trained in medicine, I was trained in infectious disease, I was trained in immunology and in molecular biology. That's a special background, but in fact, all of us have different stories to tell. I think that all we can do is try to convey a story to the next generation that works for them. I have fellows every year, we have trainees.